Welcome again. As I was saying, my name is Nancy Nealon from the Parkinson Foundation, New York, New Jersey chapter. And on behalf of the entire team who worked very hard to bring this event together, including my colleague, Melanie McLaughlin, I'd like to extend a very warm welcome. And that, in fact, is very warm welcome to everyone gathered here with us in Tarrytown, but to the 600 plus people who registered for this event via Zoom. We have a very full agenda, so I'm going to get started and get us right down to business.
Excuse me, hold me to the mic. Thank you.
Let's see, is that a little better? Yes, much better. Okay. So first and foremost, I would like to share with you the important information about the Parkinson's Foundation. We are the largest community for people impacted by Parkinson's disease. Our mission is to make life better for everyone impacted, including care partners. We do this and we work hard every day to make life better for everyone by advancing research towards the cure, improving care, and empowering and educating our global community. Next, I'd like to tell you about the Parkinson's Foundation resources. So we offer an extensive set of educational books. And to show you, or at least I did. But there are plenty across on the table. And for those of you at home, I'm going to tell you how you can access those as well. In addition, we have a whole series of podcasts and webinars and our hospital safety kit called the Aware and Care Kit. To access any of this, you can contact our helpline at 1-800 or PD Info, and they will be very happy to assist you in getting any of these materials. We're just having a little technical problem here on this end, so bear with us. I'm going to continue to share with everyone that in addition to everything I've mentioned so far, we also do PD Health at Home. I hope some of you are familiar with this already. PD Health at Home includes live new programming 3 days a week, Mindfulness Mondays, Wellness Wednesdays, and Fitness Fridays. All of these are also recorded, so you can always access them later on as well. So thanks everyone, including our Zoom audience. Thanks everyone here in Tarrytown as we work through all of the challenges, because it never works in the practice session the way it does work in real life. So now I'd like to tell you about an important study that's happening, and that is called POCAS. So the Parkinson's Foundation is partnering in a clinical trial for fracture prevention, so important for people with Parkinson's. To learn more about this, you can call our helpline, 1-800 or PD Info. For those here in the room, you can talk to Jill McClure. Where is Jill? Get her to wave her hand because she knows all about this important clinical trial as well. Or you can visit topazstudy.org. And now it is my privilege and honor to give a big thank you to our amazing sponsor. I'd like to recognize Acadia for your very generous support of this program on behalf of all the care partners that we serve. Thank you so much. for making this possible for everyone at home and Zoom and for all of us here. Thank you to everyone that included. Now, what you've all been waiting for, truly. Carol is going to be our first speaker, and such a fabulous individual to get us started here. She completed her doctoral degree in sociology and has a master's degree in public health and in marriage and family therapy. She is a professor of psychiatry at the University of Rochester, School of Medicine and Dentistry, where she holds the following leadership positions. I'm not quite sure which is time to sleep, but Carol is a director of the Finger Lakes Center of Excellence for Alzheimer's disease, clinic director for the University of Rochester Memory Care Program, director of the Alzheimer's disease support programs for the University of Rochester Geriatric Workforce Enhancement Program, and co-director of the U of R's Family Medical Therapy Training Program. Her academic interests include medical family therapy approaches to caregiving and development of family systems-oriented models of patient and family-centered dementia care. I'm so thankful that you could be with us today, Carol, so please come on up.
Thank you so much, Nancy, for that kind introduction and for inviting me to be with you today. It's a pleasure to be here. So, as a medical family therapist, I work a lot with older adults, particularly those with chronic illness. And when I usually meet with a patient and or family members, I usually start by saying this. When a chronic illness enters the family, it knocks things off balance. Family members have two options: to try to restore balance wherever they can, or to find a new normal. And that's how I describe what my job is, to help people do either of those things. So what kinds of things get knocked off balance when there's a chronic illness? Well, it's mostly how families function, how we communicate. Sometimes people communicate more. Sometimes they stop communication and avoid it altogether. Problem solving. Sometimes people who are thoughtful planning, problem solvers, just try to respond without really thinking. They react instead of planning. We know that there's roles and task changes, which we'll talk about. How people express emotion, whether they choose to share feelings, or sometimes people who have shared feelings stop talking because it's too sensitive, because the illness is like an elephant in the room. Sometimes people show a lot of concern for family members, and when there were distant relationships, sometimes they become closer, and then sometimes the opposite occurs too. And then there's a lot that has to do with behavior and power and control that changes. So what also gets knocked off balance is the self of the person with the diagnosis, as well as the self of the people who are caring for that person or who love that person. And then there's also how the family functions. So that's what I'd like to talk a little bit about today. So by the end of my time with you, I intend to acknowledge and address conflict that is felt by care partners as symptoms of Parkinson's progress. I'd like to acknowledge the loss that people feel as relationship dynamics change and as the many roles that caregivers and care receivers have moves more to one of caregiver and care receiver. And then I'd like to briefly touch on resources and professionals that might be able to help as people move through the illness process. So I will probably use the word caregivers and care partners interchangeably. I know that Tika Snow has done a wonderful job explaining how care is improved when a caregiver perceives the care as more of a partnership. But I also know that with chronic progressive degenerative diseases, as diseases progress, the partnership moves more toward the caregiving role. I'd like to start by talking about how families respond to chronic illness. So we developed this little notion a long time ago, but I call it the illness bubble, right? So when somebody starts to sense, or a family starts to sense that something's going wrong with a person, or that there's some kind of medical changes or something's different, everybody starts tuning into that thing, right? And paying attention to it. And then when you get to the point of diagnosis, you'll notice that with any chronic illness, people become absorbed with it and kind of centrally focused on it, right? I call that going into the bubble. So what happens when you're in that bubble? Well, there's a number of things. The first is that's the place to deal with shock and disbelief, right? How could this happen to me, right? Why me? What did I do? Could the doctors be wrong? Should I get another opinion, right? Trying to come up with other explanations for what might be causing the symptoms or the behavior. Then there's a huge part about grief and loss, the time to process, this is who I was, who will I become, what part of myself will stay intact and what will I lose? People start thinking that the roles that they may have held are no longer true, which of course isn't really true because what we've accomplished in our life remains a part of us, but it's hard to feel that at the time. How you wanted to use your resources. A lot of people plan to travel and do a lot of awesome things and buy a second home, and now they're thinking about how do I think long-term care? And previous relationship qualities, which we'll talk about more, and just really a loss of the future as a family or a couple had planned for it. The other thing that happens is how do we make meaning of this thing that happened? So individual couples and or families develop a narrative, a story about how to talk about it, right? You'll sometimes hear, I saw this happening a few years ago, or I first noticed it when people talk about, why it might have happened. There was a genetic influence, environmental influence. People started attributing it, the causes of the symptoms to something. And what this does is helps them find a way to talk about it. And this is also a time to figure out how people in the family affected by this are feeling about it. Right? It's a good time to talk about how the person that is a deeper dementia, but it should be a person with illness, PWI, how they feel about it, how the family members feel about it. You start to get a sense of who's going to step in and come in closer and who might back away because they're not sure how to deal with it. This is the time to figure out how you want to cope with it as a family. And how do you integrate this diagnosis with a sense of self for the person with the diagnosis as well as the primary care partner? Then it's also a good time while you're in the bubble to do some planning. That's when we look at organizations like the Parkinson's Foundation and we learn about the diagnosis, think about sharing the diagnosis, talking with the person with the diagnosis about what should the message be? What do you want to tell people? Who do you want to tell? When do you want to tell it? Finding out what the person with the diagnosis wishes and preferences are. How does the family want to cope? Who's willing to help? Who's willing to do what? And of course, it's a good time to always talk about legal and financial considerations. So that's a lot of stuff that happens in that bubble, right? Here's some things I've heard from family members over the years when they're in the bubble. I feel like your doctor's given up on her. He stopped looking for other causes for these symptoms. This isn't how we plan to spend our retirement. I want to feel better about the future. Nothing I do seems to be as it used to be. I'm isolated. I never plan to retire. We just want to get normalcy back. I miss my career, right? All of that happens in the bubble. So the thing about the bubble is once you do all of that work, you want to escape the bubble to go back to living the best life that you can live after you've done all that hard stuff, right? So that's the ideal. So a lot of times people think that focusing on an illness and really going into the bubble is a bad thing. I think it's a good thing, as long as you don't stay there forever, right? But to go in there and do all that stuff so that you can then go back to living the best life that you can live, I think is a really positive thing. And sometimes a family or a person with a diagnosis might have to go back into the bubble more than once. Say the person gets a different diagnosis, a cancer diagnosis, or there might be time for palliative care, or there might be time for something else, right? And you have to revisit it. And I think that's okay too. So another scenario to consider is that families who go into the illness bubble are usually high-functioning families. There are people who do well with communication and problem solving and expressing emotion. And sometimes there are families who aren't so likely to do that, right? Families who are dysfunctional, and you see that person outside the bubble, he or she's not going in there at all. They're going to deny that something's wrong. They're not going to walk up to doing what a doctor suggests that they do, right? Those are the hardest situations. And I feel very badly for families where there's a division in that way, right? Because some people are willing to do the work, and some people are still really scared and in avoidance mode, and they can't make plans, they can't tell people. That makes it even more isolating for the family. So that's a really hard thing, and that requires a separate intervention altogether. So let's look at changes in behaviors, and I call this walking on eggshells. So I often hear, this isn't my spouse. This isn't my mother. This isn't the father she used to be, right? Because you see different behaviors. People snap, they become angry. And I think it's important to think about behaviors and look at them and always start with a pause and try to figure out, is it a new behavior? Is this situational? Is it related to the illness or just the personality they always had? And what is the purpose of this behavior? So care partners often say, what can I do? So I think we often talk about behavior management, right? And it's a really scary thing, especially when you're talking about a 2-year-old, it's not quite so scary. When you're talking about a partner, somebody that you've been in equal with for so long, the idea of managing that person's behavior doesn't always feel so good. So in the dictionary, there's a number of definitions for management. So in this context, I like to think about to handle or direct with a degree of skill and to work upon or try to alter for a purpose, as opposed to keeping somebody in line. I think that the spirit and intent of trying to help with someone's behavior is something that matters a lot. So managing behaviors is a part of life. We socialize children how to behave in schools. We socialize people how to behave in work settings. It's just a part of life. But it becomes offensive when you're talking about managing the behavior of someone you've loved and shared a life with. So I like to think about behaviors and learning how to deal with behaviors, not from a source of power, not from a source of control, but more for the sake of safety. And also always trying to think about responding to the behavior with an eye toward what will improve the quality of life for the individual as well as for the family. So behavioral symptoms happen for a lot of reasons. Sometimes it's neurobiological, and it's often because of an unmet need. It could be relationship factors, right? In 79% of older adult families in the United States, they're very, very satisfied with their family relationships. That means 21% are not. That means that's 11 million people who are not so happy, right? Who do not have, they probably don't go into the bubble readily, right? So that's a lot of people, and we see those people in our practices too. We know that there can be environmental triggers for behaviors. Sometimes it's brain damage, sometimes it's pain or fear, or just inability to understand what a caregiver is trying to convey. So I always go back to Maslow's hierarchy of need. How many of you are familiar with Maslow? Right. Did a lot for human development. But I think when we think about behavior, behavior is communication. And it's usually communication of some kind of need. And when we think about what Maslow said, he said at one level, the basic level, we need food, water, sex, sleep, right? We need elimination, those basic kinds of things. Then the next thing we need at the base is safety. We want to make sure that we feel safe, safe with our family, safe with our health, safe with our property. Then there's love and belonging, right? Sexual intimacy. Then there's esteem, confidence, achievement, feeling respected by others. And at the top of that, we have self-actualization, morality. It's feeling comfortable with yourself and feeling like you've become who you wanted to be and you can be your authentic self. With a disease that's progressive and degenerative, at the beginning and outset of the disease, I think the needs that people express are generally more toward the top of this pyramid. And as the disease advances, what people need tend to move more toward the bottom of this pyramid. But I think that as care partners, what you always want to do is focus at the highest part that's relevant to that person, right? So to focus on food and water when they're worried about or feeling sad about losing their career, right, which is an esteem thing, right, isn't going to be a good fit. So try to focus at the top as much as possible, understanding that as the disease progresses, the needs will probably become more basic. So there have been some studies about what care receivers need, and I think this is an interesting one. And what it basically says is that care receivers also want to be able to give, right? So instead of just taking over and trying to give completely to the person, finding opportunities for that person to give back is really, really important. From that same paper, here are what some of the takeaways that I think are really relevant. That emotional bonds make asking for help difficult. So the balance is more important when there are weaker bonds. Here's what someone said. I'm no longer able to go to the toilet. I have a potty now, but my husband doesn't like me going on the potty. He doesn't like emptying it. He thinks it's dirty. So now I just don't go, but that hurts. At one point, I couldn't even be in. Those in need of care feel ashamed of becoming dependent, right? Some people say that they feel like they're part of a welfare state, that they can't give something back. And that it's more difficult to ask for help when it doesn't fit the relationship with the caregiver. So this is often the case between an adult parent and an adult child. The situation is just awkward. I'm dependent on my daughter. It's not how it's meant to be. Or the initiative must come from people themselves. It's all right if we focus more than we used to on relying on family members, friends, and neighbors, but it's a fine balance. You can't just say, your father has to do these things for you. We don't want it to work that way. You might damage the relationship if your pressure on help and care is beyond the scope of the relationship. So these are the perspectives of people who receive care, and I think they're so, so helpful. So what do we do when we have conflict? So these are just some basic overview thoughts that I had. The first thing we do is we try to prevent it, right? How many of you are familiar with the ABCs of behavior, right? The antecedent and behavior and consequence, right? So those are great things to do when you're in the bubble, right? Perfect time to talk about, if such and such happens. How do you think you'd like to respond? Or, me, I'm trying to step in. Is that what you're going to want me to do? That's a great time to have those kinds of conversations. It's also important to think about our paths as care partners to responses. When we see a behavior that makes us uncomfortable, that's the event, right? And often we go right to emotional response. But I think it's really important to go to that box of appraisal, or what I call pause, right? To think about it before we go forward. And that's when you put your Sherlock Holmes hat on, right? And you become curious about what's happening. You try to figure out what the underlying need is. When you see anger, you put the hat on and you think, okay, anger is a secondary emotion. What is the underlying need? Is it sadness? Is it frustration? Is it guilt? Right? Try to get to what it is. And the other one that's important is it the person speaking or is it the illness speaking? And I always say that you can hold a person accountable when it's the person speaking. When it's the illness speaking, we have to be a little bit more forgiving. So finally, some people say, when do I step in to help and when do I don't? When not to. So I think what I try to think about here is always thinking about the respect and dignity of the person and understanding that trying to make the person feel as whole as possible is always the best thing to do. Because if someone feels less good, they're likely to get depressed. And when people feel depressed, their functioning goes down and their health outcomes are much worse, right? So it's important to keep that in mind. So when you think about, do I step into help? Best thing to do is ask the person, would you like me to help when this kind of thing happens? Might not be able to ask in the moment, right? If it's in a fight or flight place where people are really angry, but when things calm down, ask, but how would you like me to respond to that, right? But just understand that whenever you respond, try to keep the respect for the dignity foremost, because depression will always make the outcomes worse for the care receiver as well as the care. I think validating emotions is a really important thing. Sometimes care partners want to fix everything, right? And I think about Lucy in the football, right? A care partner sometimes might come in and say, want me to do this? How about this? How about we do that? How about we do this? And every time Lucy will pull the football away, right? Because you're guessing wrong. Sometimes all you have to do is say, I'm sorry you're feeling that way. It looks like you're really sad. And it's amazing how effective that is to just validate someone's emotion, because sometimes people don't want it to be fixed. They just want somebody to sit with them to understand how they're feeling, right? So sometimes care partners work way too hard trying to come up with solutions that are going to be effective. So some things that affect behavior. Well, we know that Parkinson's can cause changes in appetite, apathy, less energy to engage in activities, and of course this affects the whole relationship, right? And it's also a difficult disease because it affects body language, speech, and the ability to show emotion, right? So if you have that part taken away, it's even more difficult and makes you really have to put your Sherlock Holmes hat on to figure out what's going on, because you no longer have access to that verbal cue, nonverbal cue, right? And we also know that Parkinson's often increases depression and anxiety, which contributes to care partner loneliness. So what makes it so hard? And I think this is what makes it hard, right? Care partners look at things and they can think rationally what's happening, but the heart hurts, right? And so sometimes we respond with our head, like, this is how I can deal with this right now. And sometimes we have to deal with it and hold it in our hearts. And that is really hard. And I think we do have to do both. But sometimes when the heart is so heavy that you can't function, it helps to try to put it back into the domain of something rational, right? This is something the person can't help. This is the disease doing this. This isn't my loved one doing this, right? And just talking about that. But there's a place for both of these things, and you can't avoid what the heart feels. So let's talk about family relationships. So this was an article that was done on caregiver burden in families with ALS, Alzheimer's, Parkinson's, brain injury, and MS. And they were looking at caregiver burden and found that the burden is greatest among ALS and brain injury, followed by Alzheimer's and Parkinson's. But they also found that family cohesion, satisfaction, and good family communication were associated with reduced levels of caregiver burden. Whereas when families were more disengaged, the burden was much higher. I'm not going to go through all these because you live all of these things And my point is to show that family caregivers take on a lot. And with the shortage of healthcare right now and the shortage of aid services and things, family members are taking on a lot more nursing tasks and things that they've never even dreamed of doing, right? What does all of that do? Well, firstly, all of these roles, the more roles that you take on, the more that it's going to move that relationship from one of equals, in the case of spouses, to one that shifts the balance and shifts the relationship from spouse to caregiver, care receiver. All of those things cumulatively add to costs for the caregiver, right, of their physical health, mental health. They might lose economic security. They can't participate with other aspects of their families because caregiving takes up so much time. They get isolated. They sometimes lose themselves, right? Make career decisions. So all of that, what it does is tips the power of balance. And it's really, really hard, especially in a spousal relationship, to feel that power and control shifting. Often the person without the power feels really yucky about it, but so does the person with the power because they didn't ask to be in that position, right? So what that power imbalance does is also affects intimacy, sexual relationships, because the more you feel like a caregiver, the less the care receiver seems like a sexual object, right? Which is something that usually comes from equality in a relationship, right? So things just get really off balance. So regarding sexual relationships, Parkinson's also brings a loss of sexual interest, sexual pain in women, problems with arousal for both men and women, problems reaching orgasm, and for people with Parkinson's, just stiffness and muscle rigidity and things like that make having any type of sexual relationship really, really difficult. So costs to family relationships, caring for a family member affects family relationships. Among caregiving daughters and sons, long-term caregivers were significantly less happy in their marriages. Family conflict is very, very common, especially when they're among siblings, you know, disagreeing about decisions that a primary caregiver is making. When caregivers were asked how much family members disagreed over the details of how they were caring for someone, 7% said very much, 13% said somewhat. That's a lot. Percentages were even higher for Hispanic caregivers, for caregivers with less than high school education, and for caregivers providing really high intensity care, defined as caring with 2 or more activities of daily living. So what do we do with this? Remember the head and the heart? Okay, this is where we go to the heart. And we have to look at grief responses for care partners. And what are grief responses? And sometimes it's walking into a bubble again, just accepting the reality and scope of the losses, right? Allowing yourself to experience the pain of loss and adjusting to that new reality. And it might be a cycle that you go through all of these in different, in a different order, and also over and over again, right? So I know I'm running out of time. So I think that what helps is allowing yourself time to experience the thoughts and feelings, remembering that crying is okay, finding somebody to confide in, and seeking professional help and the resources like those of the Parkinson's Foundation. I'm going to stop because at the end of my time, we do have access to my slides, and we will have questions and answers. And if you have any questions, my email is at the back. Thank you so much.
Okay, welcome back, everyone. Thank you for your patience as we navigate having both in person and Zoom simultaneously. So happy that you are gathered here on Zoom and with us here in person. And now it is my honor to introduce our next wonderful speaker. And thank you again, Carol. At this time, I would like to introduce Dr. Katherine Amodeo, who is a movement disorder specialist, Department of Neurology, Westchester Medical Center at MidHudson Regional Hospital in Poughkeepsie. She is also assistant professor of neurology at the School of Medicine at New York Medical College. Dr. Amodeo is a neurologist who specializes in the diagnosis and care of patients with neurodegenerative, movement, and cognitive disorders, including Parkinson's and dementia with Lewy bodies. She completed fellowship training at the University of Rochester as a selected Edmund J. Safra, Michael J. Fox Foundation Fellow. She has served as principal investigator and co-investigator in several clinical trials in Parkinson's disease and dementia with Lewy bodies. Dr. Amodeo evaluates and treats patients with neurological disorders with a focus in movement disorders and cognitive disorders. Her research interests include identifying modifiable risk factors for cognitive impairment and making hospitalizations safer in those with Parkinson's disease and related orders. So a great segue as I plugged the Aware and Care Kits just a moment ago. Dr. Amodeo, would you like to join me up here?
Thank you, Nancy.
So double. Now we're just tapping in just a little bit.
Okay. Thank you so much, Nancy. And it's so wonderful to be here in person and also with our Zoom audience. It's especially been wonderful for me to see some of my colleagues from Rochester again. So that's been great. All right, so today what I'm going to talk to you about is just a brief overview of understanding cognitive changes that may occur in Parkinson's disease. So the point of today is just to talk about some cognitive changes that we may see in Parkinson's. I often get questions, about how do I know if this is normal aging? Is this part of the disease? Is this something more severe than mild cognitive changes like dementia, which we'll talk about? The point, though, again, it's not to scare anyone. That's not what I want today. What I want to do today is equip you with knowledge so that you can understand yourself and your loved one going through this disease. Know what questions to ask of your provider, and then understand the available treatments we do have for this aspect of the disease and when and why it may be beneficial to your loved one. So Parkinson's is primarily characterized by the motor features. I think we've all affectionately come to know, the motor features of the disease, intimately, I should say, the rest tremor, the bradykinesia, the rigidity, the postural instability. But it's increasingly recognized are the non-motor features of the disease that sometimes are hidden under the iceberg that we're not seeing, but can be, just as impactful in this disease for you and your loved ones. We know there's a dysautonomia with constipation, anosmia, or reduction in sense of smell can be an early feature. And something we're going to talk about obviously today is the cognitive aspects. Now here I have 30%. That was a point prevalence. So that's if we look at anybody with Parkinson's, all comers, we'll see about 30% of individuals will have cognitive changes. So not everyone with this disease will experience cognitive changes. So I want you to know that. Now, if we look at a pool of those with Parkinson's who've had the disease for more than 20 years, or 20 years or longer, that prevalence goes up. So we do think cognitive changes are more common the longer you've had the disease. But again, that will not be true for everyone. The big messenger of the brain, or the neurochemical of the brain behind Parkinson's, is dopamine. Again, I know many of you know this, and dopamine is that, behind the motor features, but it can also be behind attention issues, focus issues. Dopamine is needed for focus. And so some of you, may notice this when you're having some fluctuations in your motor features, may also experience some cognitive fogging. But there are other players in this disease, and the other messengers are norepinephrine, which is behind a lot of the autonomic dysfunction, like constipation, like orthostatic hypotension, or that propensity for your blood pressure to get low at times. Serotonin is behind, mood changes, which again, we heard earlier that depression and anxiety can be common non-motor features of the disease, and it's important to recognize because there's treatment. And then acetylcholine is the messenger that we know to be most responsible for the cognitive changes. And this is important as we think about the treatment options. That's why I brought that up. So I often hear, how do I know this isn't just normal aging? I walk into a room and I might be like, why was I here? But then it comes to me. And certainly those are some changes we can see with just normal aging. Our job together is to figure out when is it more than that? And we often talk about what else is occurring. So is it persistent? Is it pervasive? So is it in all aspects or just a few aspects of your life? Is it getting progressively worse? So maybe you've noticed some short-term memory issues, but now it's getting a bit, things are marching along perhaps. That wouldn't be part of, normal aging. Is it a significant change? So I'm always asking about, what was it, how were you functioning maybe a year ago? How are things different now? Are there things you're needing help with in your day-to-day that you used to not need help with? And what is your impact on function? That's the big key when we talk about normal aging versus this being part of something bigger. Normal aging, actually, I guess, which is reassuring, with normal aging, you remain independent with your function. So when there's an impact on your function as a result of cognitive changes, that's when we're worried about something more going on. The important thing is when we talk about cognitive changes in the context of the disease, it should not be acute. It should be something that gradually changes over time. Any acute change, be in touch with your providers because we have to make sure something else isn't going on. Is there a new medication? It's amazing how for some individuals, medication changes can cause a big change in our thinking. So we have to identify that. Is there infection? A urinary tract infection, for example, can really cause a lot of changes in thinking. And sometimes that's the only way it's presenting. And so it's important to recognize that because that's treatable. So it shouldn't be acute. When it's acute, we have to look at other things. But when it's something that's gradually occurring, and when it's something that's persistent, it's not going away, that's when this may be more. And this may be part of the cognitive changes we see in Parkinson's. It's not synonymous with dementia. There can be different severities of cognitive changes. Very early in the disease, some individuals may notice slowness of thought. We call it bradophrenia. So we talked about bradykinesia, where that's the slowness of movement that we know to be a motor feature of the disease. We can also have bradophrenia or slowness of thought. And I often hear this, I know what I'm thinking. I know what it is. It just takes me a little longer to bring it forward. And I say, yep, just give yourself time. Be kind to yourself. It will come forward. So that can be an early change. And that's a very mild form. And then obviously, there can be more severe stages. There are multiple domains of cognition. So I think when we think about our thinking, we often think about memory. And so, I may hear, oh, no, memory's fine. That, my loved one remembers more things than I do. but there are actually other domains. And in Parkinson's, other domains are actually more disproportionately impacted than memory. So when we think about early memory changes, that actually may be the pattern seen in a different type of dementia like Alzheimer's. But early cognitive changes in Parkinson's actually may be more changes in attention. So being able to focus on a stimuli and kind of tune out other things. And executive functions, so the ability to plan, multitask. Those are the domains that are disproportionately impacted, as well as visual spatial. So the way that we see ourselves in our 3D world. but memory certainly can be impacted too. So attention and executive function, what do I mean by that? Again, attention's the ability to filter information among a lot of noise and background in our world. And executive function is that, we think about what an executor does for a business. They plan, problem solve, just carrying out tasks. An implication for real world is driving. So even in early stages of cognitive impairment, we may be having discussions about driving safety just because we know driving requires so much, right? It's actually the hardest thing we do every day. We take it for granted, but we need to be paying attention. We need to be able to anticipate the next move of the driver in front of us. So it requires a lot. Dopamine, we talked about, is critical for regulating attention, and it needs to be just right. And so with Parkinson's, when we're taking medicines that help regulate our dopamine levels, sometimes we can get these valleys, sometimes we can get these peaks. And even at the time where maybe our motor features are the best, we're moving our best, we're at our peak, we might be thinking a little different. We might be actually having trouble with attention because we're just so on, as we might say. So dopamine can play a big role, and you may see this in your loved one as they fluctuate, if fluctuations are present. Visual spatial disorientation is one of the other common features of the cognitive changes we may see. And so those of you who've seen your neurologist may have been asked to draw the clock. That's one that we often do because it tells us a lot about both memory, but also the way that you're able to see your 3D world or your world around you and orient. Driving is another big example of this in the real world, the way that you are able to orient yourself in your space. Facial recognition. So I might hear this from loved ones or my patients that, having a harder time recognizing those faces around you. And again, that is due to this visual spatial impairment or depth perception. So I'll hear from my families, driving is a little bit different because there might be less space between the car in front of us. And that is something to talk about. So memory impairment, by and large, long-term memory is intact, but in early stages, we may have trouble with short-term memory. And that's because you need attention to be able to remember something. So if you're not fully paying attention to a new fact or a new statement, you're probably not going to remember it. And it also, sometimes memory impairment is misinterpreted for that bradyphrenia, that slowness of thought. So I will say, again, give them time, give your loved one time, because they probably do remember it. It's just taking a little longer to come forward, or give category cues, things like that. For our patients, or, as you're caring for your loved one, think about ways to make things simpler. Lists. It is perfectly fine to have Post-its and to-do lists around the house. They can be very helpful. Language impairment. So by and large, language is preserved, and my avid readers and my linguists remain, lovers of language, and that remains intact. What we do see in Parkinson's is more of a tip of the tongue phenomenon. So, meaning it's not so much trouble with knowing the word, it's getting that word out. So that retrieval of the word is what we see. More severe speech problems, again, may suggest an alternative diagnosis like Alzheimer's, where we know language is disproportionately impacted. So now we talked about the different changes that can occur, and it can be single domains, just one of those domains impacted. It can be multiple domains. When we start to see more domains of thinking impacted, that's when we start to see impact on our function, where we're needing help. And so when there's this progressive change in memory and thinking and processing impairment that now impacts our day-to-day, where we're needing help with things we didn't need help with due to cognitive trouble, that by definition is dementia. And so dementia is just a word. It's a word that means there's been a change in our memory and thinking and other domains that's impacting our function. And there's a broad differential, but obviously we're talking about it in the context of Parkinson's. And when we start to see that, we actually put it under the umbrella of Lewy body dementia, which is another term that you may or may not heard of. It can get a little bit confusing, but that's what we mean, is that there's Parkinson's now with dementia. Not everyone with Parkinson's gets dementia. I want that to be clear. And we still don't really know why some individuals with Parkinson's develop dementia and others don't. There's some thought that the older you are at the age of onset, the more likely we're to see more severe cognitive changes meeting criteria for dementia. The longer you've had the disease, so those who've had it for over 20 years, it's more likely. And the way that you present, so your initial symptoms of Parkinson's, so those who maybe present without tremor, so their initial symptom is not tremor, we think it's maybe more likely in that phenotype. But again, this isn't true for everyone. I think we all know that Parkinson's can look very different for individual to individual, and that is true. The good news is there are things we can do to help this, okay? And that's why I want us to recognize this and talk about it just as you do your motor features with your doctors. We know that from a non-pharmacologic approach, diet, exercise, socialization, and strategies to help you can be extremely helpful. In fact, exercise is the one thing we have that can actually change your course, change your risk. And that's what's pretty cool. And then when we talk about a pharmacologic approach, remember at the beginning of my talk, I talked about how there are other neural messengers of the brain involved, acetylcholine being the one that we think to be behind the cognitive changes. And so when we talk about medications that could help in the more severe stages, when we start to see changes consistent with dementia, we use medicines that help keep acetylcholine around. And that's the acetylcholinesterase inhibitors. Rivastigmine actually being FDA approved for this indication in Parkinson's and dementia, and Aricept, which we often use, we've been using for a long time. And that's the conclusion of my talk. It was just an overview for you. Thank you. Yes. Yes.
Such amazing information that we've shared already this morning. And now it is my honor and pleasure to introduce our last keynote speaker, Amanda Brill. So as Amanda joins us up here, she is the lead clinical social worker from Hartford Healthcare and Neuroscience Institute, the Chase Family Movement Disorder Center, which is now a part of the Parkinson's Foundation Global Care Network, designated in 2022 as a comprehensive care center. Once again, us advancing care. She joined the Chase Family Movement Disorder team in 2017 as their first social work clinician, provide much needed behavioral health services to people with Parkinson's and their care partners. Today, she continues to provide behavioral health care to patients and families and mentors new social work colleagues on the psychosocial complexities of Parkinson's disease. Prior to 2017, she was an employee, of the Yale New Haven Health System as a psychiatric social worker on the inpatient older adult unit. Amanda was born and raised in Connecticut. She attended SUNY Plattsburgh and Southern Connecticut State University. So join me in welcoming Amanda.
Okay, can you hear me?
Oh, excellent. Just sweet spot.
Okay. Thank you to the Parkinson's Foundation for inviting me. I'm very excited and happy to be here today with everyone. So managing thinking changes in Parkinson's disease and the care partner journey. I'm going to speak about acknowledging the feelings care partners experience when they observe changes in their loved one's thinking and memory, and identify tools and strategies to assist care partners with the cognitive changes in their loved one. So first, I thought talking about there is a slight difference in between emotions and feelings. Emotions tend to be much more physical and instinctual, and feelings tend to be more conscious awareness of how we interpret that experience. This is an emotion wheel. Usually you'll see emotion wheels with the primary and secondary feelings and emotions on the inside, and radiating out they become more, I think, more detailed, more descriptive. So there's a lot of feelings within maybe one larger emotion. And making sense of where our feelings and emotions come from. I like to look at the cognitive model, or the cognitive behavioral therapy model. So oftentimes a situation occurs which brings about a thought, our thought about the situation, and that then turns into an emotion or a feeling. And then we act in a way, or we behave in a way. And when we're talking about changing our emotions or changing how we feel, it's hard to target that directly. And so oftentimes therapists or clinicians will look at targeting the other aspects that are there. So we look at targeting the thought that you have, or the behavior that is performed, or we try to modify the situation. And that in turn can change how you feel, or the emotional response. Care partnering in Parkinson's, I just wrote down on each side that there's a lot of positive, loving experiences and feelings and emotions. Love, affection, compassion. A lot of people feel that it is a growth process for them. And then there are also a lot of negative emotions, and it's going to include both for both individuals, actually, for the individual with the disease and the care partners. You will have conflicting emotions, feeling angry and hopeful in the same moment. There are, no emotions you should or should not feel. One of my things as a clinician is we need to eliminate the word should from our vocabulary, or should not. It places pressure. And then there are the roller coasters of the ups and downs, the highs and lows. So Carol spoke a lot about balance and finding that balance, and when it shifts and becomes unbalanced. And that also is somewhat of a kind of framework for my talk as well. Grief and loss is a big part of the Parkinson's journey for the individual and the care partner. I mean, grief at its core is a response to loss. It can be emotional, physical, an adjustment, a healing process. This is the Kubler-Ross grief cycle. I think we've all maybe heard it or come across it. Denial, anger, depression, bargaining, acceptance. And I think that throughout the journey, the individual with Parkinson's and the care partner goes through a grief experience. There are different types and forms of grief. One of them is anticipatory grief. It's felt in anticipation of a loss. It doesn't have to necessarily mean death or dying. It can be a loss of functioning, a loss of part of your relationship. It can be a loss of work or employment. It can be any type of loss that you're anticipating. And ambiguous loss or grief is when something or someone profoundly changes. A person feels torn between hoping that things will return to normal or the way that they were, and a looming sense that their life as they knew it is fading away. So often occurs without closure or clear understanding. And that can lead to people getting stuck in this unresolved, frozen feeling of grief. I think that the quote next to the Wendy Alsop, that quote speaks volumes. The loved one may still exist in your life, but they are not there in the way your relationship was experienced in the past. So as you know, grief is a process that, you know, we as humans will go through at some point, all of us in our life with a significant loss. So this is living through the highs and the lows, the emotional roller coaster, the waves of emotion. So oftentimes we talk about, you know, that there are highs, there are lows. The emotions can come on, the feelings can come on and be automatic and reactive. They can be high, intense. And what we talk about as clinicians is trying to creates greater stability, a greater emotional regulation. So moving from the highs and the lows and the roller coaster to, you know, waves in the water, like small ripples, and a roller coaster, which, believe it or not, was hard to find without so many ups and downs and twists and turns, because you know, it creates a feeling of stability, less reactivity, which is important. We all talk about, you know, minimizing or limiting stress for the individual with Parkinson's. And so also, I mean, the care partner is a big part of that, and their responses to things and situations. So talking about care partner self-care, coping for care partners, you know, you hear about, you need to take care of yourself. You need to do self-care. And I don't know that, I'm sure along the way, people figure it out and they at some point say, okay, this must be what self-care is. But I'm not sure people know, or care partners know, what self-care means or what that looks like in, I guess, real life. So this is, you know, kind of my version of or some thoughts that I have on self-care. It's an emotional support, and I think all care partners should or would benefit from getting emotional support, as from a psychotherapist, from a support group, from friends, a psychiatrist, a geriatric care manager. I do think that therapists can be very helpful in having a space to talk about your experience, for somebody to ask you as a care partner, how are you feeling today? How are you doing today? I think I put down also like the timeline, you know, how often. I think monthly meeting with a therapist or a support group, both maybe, you know, I would recommend. I also talk about looking inward first, so processing and understanding your own thoughts and emotions first. So before you know, you discuss with your care partner an incident, or before the care partner discusses with the person who has Parkinson's an incident, think about, go through your head, think about how you felt, what emotions came up for you. Gentle acceptance, self-compassion, and using your values and goals to guide your actions. So really think about what's important. What are my goals? And how can I use those aspects of your life to guide how you care or how you relate? Physical and mental self-care. Pick 1 or 2 group exercise classes, art classes, something that you as the care partner enjoy and attend on your own, like weekly. So I find that it's very important for the care partners to have something that they attend on their own as an individual, that's for them and their health and wellness. Spiritual connections, set up regular social events with friends, family. Try to schedule them the same day or time of the month So on the second Saturday at 1 o'clock, we're going to meet for lunch, peer and caregiver support groups usually happen, the third Thursday of the month at 4 o'clock. So trying to schedule those to be built into your schedule and your plans on a monthly basis. There is this concept, and I'm not sure how many people are familiar with it. A psychologist really has written books, her books and her information, Susan David, and she goes over emotional agility. Emotional agility is the process that allows us to be in the moment, changing or maintaining our behaviors to live in ways that align with our intentions and our values. So emotional agility, I feel like, is an important concept to understand, to try to look at it as a care partner. And a big part of understanding emotional agility starts with understanding how you felt. So labeling your emotions, being as specific as possible. What were you feeling? Practice gentle acceptance, so embrace the reality of the present moment and live with your values, making choices that bring you closer to being the person you most want to be. Emotional intelligence, again, is when we label our emotions accurately, we're able to discern the precise cause of our feelings. So as the chart shows you angry, sad, anxious, hurt, and under each of those are kind of versions of, or degrees, I guess you can say, of feeling angry, sad, anxious. So with that, we talk about going beyond the obvious emotion and trying to really get granular in this identification of how you felt. So layers of the emotions. So I, go beyond the obvious anger, and I was irritated or I was offended, because that can give you a different way of thinking about it and a different understanding and response. Coping with grief. This goes over intuitive grievers tend to display more emotion, and they cope by sharing their feelings, sharing a common experience, talking about their loss. So these individuals really get community support from a therapist. Instrumental grievers direct their energy into activities. So these individuals are more likely to express their grief by creating memorial walks, remembrances, a foundation, garden. So, and most people do grieve using both of those kind of strategies. This is quickly just in terms of, Carol already went over Maslow's hierarchy of needs, and that is on here, but there's also a pyramid of emotional needs created by Susan David on emotional agility. And she goes over kind of the top is what we all strive for is wisdom. Life's beauty is inseparable from its fragility. And along that kind of pyramid, we go up that's, wisdom is the highest level of the self-actualization on Maslow's. And you could see kind of the different emotional needs. Gentle acceptance is at the bottom. We all need gentle acceptance and compassion. Routine, connection, courage, reset, and wisdom. Building resilience, meaningful, purpose, intentional, choosing to be intentional about something every day. So how do we build resilience? This is a concept too that you'll hear a lot about as caregivers. The resilience is the ability to bounce back, right? The ability to live something that's very difficult, adverse, and we can bounce back from it. Connection is protection. I heard at one point, and I said, oh, I love that. The right to choose everything. Viktor Frankl is a well-known writer. So everything can be taken from a man, but one thing, the last of the human freedoms, to choose one's attitude in any given set of circumstances, to choose one's own way. And positive psychology, attitude of gratitude. So practicing our gratitude. These aspects build up our resilience. Radical acceptance is a concept around looking at the kind of, and I think it takes time to get to a point of where we can, have radical acceptance. But if you think about pain and not acceptance, it really causes some additional suffering and some more suffering. Acceptance of things as they are, understanding what we can and cannot control, right? So the area, there's circles on the side, circles of influence, factors that I can control and are within my control, and factors that I can't control. There's always those aspects, both of them. And, looking at the factors that you cannot control, we need to learn and practice how to come to radical acceptance. When asking for help from others, so care partners, when you're asking for help or seeking help, remember to be specific, detailed, precise, direct. So ask for something specific. When somebody says, I'd like to help you, or what can I do to help you? Accept the help, but be specific. Can you come over on the second Saturday from 2 to 4 because I have a support group that I really like to go to? And can that be set in the schedule? Can that happen once a month? So trying to really tell somebody specifically. Mantra meditation. A mantra is a motivating chant, a phrase that is often repeated. So I think something that you believe in moments of extreme kind of frustration, that high intense frustration or sadness, trying to say to yourself something over again, whispering it to yourself, it increases your focus, your self-awareness, and improves your quality of life and mental well-being. So I just gave some examples. I can and I will. Give me strength, give me courage, give me peace. I think we all kind of talk to ourselves at some point, but self-talk and using a mantra really helps reset your focus. Mindfulness, notice your feelings, your thoughts, rather than getting entangled. It creates this space between thought and action. So when we need to think about how we want to act or behave, we really are encouraging people to be mindful. Tools for your toolbox, it just goes over some of the kind of realistic optimism, journaling, some different tools that care partners use. I think journaling is particularly helpful. It helps you think about like your emotions, your feelings, your experience, almost as like you're talking to yourself. You're your own therapist. So respecting that your journeys are different, encouraging safe independence. I say always do not be so quick to help take over or to take on, allow the struggle for some period of time. If your individual with Parkinson's is struggling with something, allow them to struggle a little bit and then say, would you like me to help you with that? May I help you with that? I'd like to help you with that. And tools for communication and engagement. I might be up on time. So I'm going to just run through these quickly. And creative problem solving. And I did give out some resources on books and podcasts for family caregivers that you might want to check out and listen to. And just some of my big kind of things that I try to express. It's a marathon, not a sprint. Being proactive and preventative versus reactive and responsive, I think is really a big one that I try to empower care partners to look at. And thank you. It's been a pleasure.
Thank you, Amanda. Thank you so much to all of our speakers, and they will be back for our Q&A. But now is an especially poignant and important time for us to hear from care partners themselves. So I would now like to invite up Rick, Michelle, and Dottie, and they are going to join me up here. We've actually decided to ask our care partners to introduce themselves. So Dottie is holding the microphone, so I'm going to guess that might mean Dottie's starting. Is that correct?
I think so.
Okay.
My name's Dottie. I'm from Baltimore, Maryland. I'm care partner with my husband, Stan, who was diagnosed about 15 years ago. And a quick something about myself, which we were asked to give, is that my husband and I have two incredible granddaughters who are as opposite as they could possibly be, except they're both incredible artists.
So nice. Thank you, Dottie. Michelle's going to go next.
Hello, everyone. My name is Michelle Coleman. I was born and raised in New York, Westchester County. I'm a caretaker to my father, Robert. Me and my sister became a team, taking care of him. My father was diagnosed in 2014, and by learning about PD through the foundation, I realized that he showed signs of PD before 2014. So awareness is very important, especially if PD runs in your family. I'm first generation Paraguayan American, and I'm blessed with 2 kids and a supportive boyfriend. I'm trying my best to balance daughterhood and motherhood. And by taking care of my father, it restored my faith and taught me patience. Thank you.
Thank you, Michelle. Last, but certainly not least, Rick is going to introduce himself.
Good morning. My name is Rick DeCandio. I live about an hour north of here in Modena, New York. I am the caregiver for my father-in-law. And we'll go through a little bit more of that. I used to be a trade show manager, so I was on the road pretty much every day for about 200 days out of the year. And then that came to a screeching halt thanks to COVID. So from there, I found early retirement, and now I'm taking care of Dad. So.
Wonderful. Thank you so much. So as you can tell, we have such richness joining us here on the stage. So our first question is posed to each person, each care partner. Can you take a moment to share how you adjusted and adapted to your role as a care partner after your loved one's diagnosis? Dottie?
Thank you. My first role when my husband was first diagnosed and still able to be very active, I call it accommodations manager. And the goal was to simply be able to keep doing all the things we loved doing together as much as we possibly could. So a walker that was right for a person with Parkinson's, doing international travel and figuring out how to do wheelchairs everywhere, how to make sure places were accessible, how to have beds that either were big enough for both of us or separate because of the night terrors that he had very early on. And ultimately of selling our 3-story house and moving into an apartment with an elevator. My second identity was full-time caregiver. That meant the goal was taking care of safety and basic needs. We found our possibilities for doing all the things we had loved to do shrinking considerably. Stan eventually stopped wanting to do anything that he used to do to help at home, so that the caregiving got deeper and deeper. We were both suffering from lack of sleep because of the night terrors getting worse and worse and worse. This was before Nuplazid was available. And that phase kind of ended with our children, our friends, and Stan himself all insisting that I give up that role of full-time caregiver. So the next stage, which we're mostly still in, was, I call it problem solver and long-term care activist. The goals here are safety and having basic needs met, maintaining social connections with family and friends, and finding ways to experience joy in our lives still. That has involved learning the systems, CMS, CDC and COVID, all of those things, the difference between assisted living and full nursing home care. Then COVID hit, that changed everything. That's where the activism started. First saying, we have to see our loved one. Yes, COVID is dangerous. Yes, we have to pay attention, but the staff come in every day. At least 1 or 2 family members should be able to come in every day. And working together, Stan and I, for setting the priorities for the problems that most needed to be solved, because in long-term care, the problems are endless. And one of my biggest tasks is organizing our friends and family to spend time with Stan without tiring him out.
Thank you, Dottie. We're going to go next to answer that question about adjusting to your loved one's diagnosis.
Yeah, so I have a little bit of a unique situation. We found out that my mother-in-law and my father-in-law both had not just my father-in-law with Parkinson's, but my mother-in-law was diagnosed with Alzheimer's. So Pop, he was her primary caregiver for the longest time. So they hid it very well from us. And we kind of guessed that he's been living with it for about anywhere between 5 to 7 years. They kept to themselves. And when COVID came around, wow, they really kept to themselves. And we applaud that they didn't go out very much. However, that created a whole bunch of issues, for Pop. He let himself go. He didn't take care of himself. He was busy taking care of Mom. Mom was on that 10-minute loop of questioning, and we saw his crankiness increase from, being acceptant to what the are you talking about? Okay. So when we got finally involved, it was right around Christmas of about 2 years ago. And we were allowed, they allowed us to come in and see where we are. And I jumped in, starting to do their shopping for them, because Pop with Parkinson's, we weren't too happy that he was still driving. Luckily, he was only driving a mile away. So with that being done, I was taking him. We decided, my wife and I said, I'll take care of Pop, you take care of Mom. Okay, Mom, and she took care of her doctor's appointments, and I got Pop. Took care of him with his doctor's appointment, became his advocate. Also did the shopping, some cooking. We hired a housekeeper to come in and help them, because Mom couldn't do the simplest of tasks because of the Alzheimer's. She would start something and that would be the end of it. When we started doing this, Mom fell into a deeper issue and she got hospitalized. When she was hospitalized, I was Pop's primary at that point. I stayed with him for every day, anywhere between 12 and 18 hours a day, trying to assist him in his dailies and seeing what he really needed and what he did. And I watched him over the course of 10 days crash. And it became to a point where he needed to be in the hospital himself. He was also diagnosed with some kidney failure that was happening. Okay, so we later found out that he has prostate cancer, and that had metastasized to other things with the ureters. So now we're dealing with that. So we got multiple things happening. We took care of it while he was in the hospital. We took care of a surgical procedure that helped him and his kidney failure. Unfortunately, he had to go to rehab. And unfortunately, even more, his Mom had to go on hospice. So with Pop down in rehabilitation, We picked a rehabilitation facility that was Parkinson's oriented. He had no exercise, no nothing. When he walked in, he was in a wheelchair when he walked in. While he was in, we lost mom. So now we've got grief on top of everything else that he's dealing with. So our biggest goal was his mental state and how do we keep him positive? So luckily they were very helpful with this in this facility. And he came out with a full 180-degree turnaround. He walked in a wheelchair. He came out walking in a walker. And we were like, wow, this is fantastic. Okay. He also came directly to our house. He didn't go back to his home. So now there's that change that's also incorporated into it. When we started with Pop, we've managed to keep him moving and progressing. And I'll get to that in a few extra minutes.
Thanks, Michelle. You're going to tell us now about your adjustment to your dad's diagnosis.
Yes. So I now have many hats. I was in dental for the past 5 years during COVID. And I never thought I was going to be entering the medical field. So this is a new change for me and a new adjustment. And for some reason, I'm a natural to it. I have no idea how, but I'm just taking it and I'm going with the flow. So I would like to share a story. Growing up, my father encouraged me to speak Spanish at home and English at school. It is very difficult to balance both languages, especially when you have to translate them with medical terms and body parts in Spanish. So we were at the eye doctor and the doctor wanted my father to blink. As I was translating, I froze mid-sentence because I forgot how to say blink in Spanish. So I have to speak to my dad like this because he's having some vision problems. So I'm like, Papa, blink your eyes like this, you know, trying to make that motion of blinking. And he looks at me with a confused, puzzled look. ¿Qué? What? So now it just made me realize, oh my God, I really have to brush up on my Spanish now and understand the medical terms in Spanish and the body parts in Spanish so I can properly relay it back to my father so he can understand what is going on internally and outside of his body. So that kind of made me realize I have to embrace my Paraguayan culture more while I'm taking care of my father. Thank you.
Well, that's such a significant observation. Wow, Michelle, thank you. Okay, so I know that this is going to be challenging, but I'm going to ask if each of you could give us 2 to 3 of your most helpful strategies or resources that have assisted you or your loved one coping with thinking changes. So 2 to 3 strategies in relation to your loved one's coping with thinking changes, excuse me.
So I got 3 strategies. Okay. First of all is every morning when I wake up and I see my father-in-law, I assess the day and I see how he's doing. And I ask him basic questions on how he slept, how everything was. I don't expect him to be 100% every single day. We're never 100% every day. We all get cranky. We all have our bad days. We have our good days. Some days he moves slower than normal. On those days, I kind of assess and maybe we'll move his medication, his carbidopa up just a little bit so that it will get a little extra into his system so that he'll move. But I did want to let you know, I partnered very closely with his medical team, okay, his neurologist, his urologist, and his primary care. We found a group that both the primary care and the neurologist are in the same group, so they share his medical records. The urologist is not, but we've insisted that we get the medical records for them to share. And we then will either bring them or have them sent to the primaries and to the urologist. So if he has a blood test in urology, it goes right to the primary. So everybody's well equipped to go through this. Exercise. For him, it works. Okay, it really does. Rock Steady Boxing. Awesome program. If you have a loved one who can do it, great. Pop had a hard time moving from station to station. So we got him one-on-one with that physical trainer, and he has his own personal training twice a week. As leaps and bounds, okay? Physical therapy he's in that twice a week as well. So 4 days a week, he gets physical therapy. And we've seen it. And remember, I just said, he went from walking in a wheelchair, coming out in a walker. Well, walker to wheelie walker, and now he's on a cane. And sometimes he doesn't even use the cane around the house. So great, great progress there. Communicate with and be the advocate for him or her or whoever you're dealing with. Because if you don't do it, he's not going to. Okay, you have to be the one driving with the neurologist, driving with the urologist, driving with the primary. What can you do? Tell them what you're seeing. As what we do is we put a diary together, and we started doing that with Mom because they were seeing the same neurologist. And to keep it straight, we wanted to make sure that we tell him about her problems as well as his problems. So we've chronicalized every single doctor's appointment. We have a sheet that has every single medication that he's ever taken on to it, what's been stopped, what continues. And we sit down with that doctor and we say, what are the interactions? Because now I've introduced 2 cancer drugs into his system along with prednisone. So what do we do with that other than continually feed him, because the prednisone has made him extremely hungry and he's eating me out of house and home. So knowing what those interactions are huge, huge help. And finally, this has nothing to do with them. This has to do with the caregivers. Find time for yourself. Make time for yourself. Find a home health aide to help you. You can't do it all. You're going to go through burnout and you're going to get there quick. You're going to be like, again, don't get to that point. You have to have your own mental health, and it has to be for them, okay, and for yourself. Get those days, go for a manicure or pedicure, find somebody that can help you. There are 24/7 healthcare aides that if you need to get away for a girl's weekend or a guy's weekend, do it. Okay, do it. And don't be ashamed of doing it. Don't be afraid of doing it. It's your cleansing breath that you need. And it really helps.
1-800-4PD-INFO is a great place to start to get those questions about where do you find help. Michelle, your strategies?
So my father's having a hard time accepting his Parkinson's disease. He kept it hidden from us for a very long time. He gets emotional and asks, why is this happening to me? And I try my best to console him. And I keep it in the loop during the doctor's appointments. So I motivate him to talk to the doctors. Dad, please ask me questions. Do you have any questions, Dad? Talk, say something, express yourself. And it's really difficult for him to express himself. So I tried to navigate that and guide him through his emotions and what he has to say in Spanish. And I tried to encourage him to talk English as well. But right now we're at a point where he speaks more Spanish than English. And he also talks another language in our country, which is Guarani. Unfortunately, I don't know Guarani, but he talks to me in Guarani. And I'm like, okay, Dad, okay. And I don't want to tell him I don't know Guarani. I don't want to disappoint him. So it's important when you bring someone with PD to a doctor's appointment, let them know that what they're here for and why they're visiting the doctors. And it's important for the doctor to understand that they need to be patient with the PD patients as well. You're going to be repeating a lot, and it's hard to keep track of what the doctor tells you at that moment, the visit, during the doctor's visit. Because when you leave the facility, you forget everything. So it's best for you to bring a notebook or some type of pen and paper to jot down what the doctor tells you. So then you could read it back when you're home or when you're by yourself and relay back what happened during that visit so you can keep track. He's also having a hard time adjusting at the nursing home because he wants to go back home to Paraguay. He's having difficulty understanding that he's receiving the best care here in the United States. And he's currently at a beautiful and safe facility. So in his mind, he thinks that me and my sister are abandoning him at this place. But it's hard to explain, no, Dad, we're not. We're just going to leave you here temporarily until you get better. You need to walk. You can't leave here until you start walking. So that's another adjustment. And it's really sad, but I have to let him understand that you are here in the nursing home to benefit your health, and they will take care of you. They have the resources here that I'm unable to provide. Location matters when visiting a doctor's office. Since my father's in a wheelchair, I have to be cautious of the surroundings. I encourage you to use Google Earth or to go in person at the doctor's office to see if they have the space available to load and unload the patient when you're using ambulatory transportation, because that's very, very important. I went to a doctor's office and I forgot to do my research, and it was a very busy intersection, and the ambulance personnel was like, this is not a safe place to unload and load your father. And it dawned on me, I'm like, oh my God, I didn't do my research. So now I have to be really attentive when I pick the locations of the doctor's office to see, am I able to bring my dad to the front door? Am I able to push my dad with the wheelchair and hold the door and up that ramp? Can I do it by myself? So a lot of people see me struggle with the wheelchair and my bags and everything. I said, no, I don't need help. I need to do this by myself. I need to figure out what works with me while I'm out with my dad, and what doesn't work for me, so I can better prepare myself. I created an adult baby bag, I like to call it. I have a backpack when I go out with him. I have my clinicals with me. I have extra diapers. I have all the materials, wipes, hand wipes, everything. And when I struggle with the door, I figured out I'm going to use my heavy backpack as a door stopper so I could push my dad through with the door with his wheelchair. Great idea. And that's, let me see. That's it.
Okay, excellent. Thank you so much. And Dottie will complete the
Thanks to
panel.
Rick and Michelle for covering all the things that I've been through. So I'll stick to advanced Parkinson's with dementia, Lewy body dementia, which is where we are, my husband and I. So what I would add, one is, if you don't have a neurologist who specializes in Parkinson's and movement disorders, please find one. That was a turning point for us very, very early on. Secondly, now what's become very important is for Stan and I together to plan his week, for him to know who's going to be visiting what day, and to try to build in once or twice a month something special for him to be able to enjoy the kinds of things we used to enjoy, but on a kind of different level. And most of all, and what takes a lot of my thinking these days, is dealing with the Lewy body dementia. We have actually together, Stan and I, worked on helping him recognize when he's hallucinating. And even though it doesn't take the hallucination away, the fact that he can, at this point, he's able to say, he's telling me about something that happened, it's very detailed. He's in Philadelphia at a restaurant with good friends and having a fantastic meal that he tells me about in great detail. And then he'll suddenly go, oh, this is a hallucination. So he actually understands it, which fascinates me, because I have a degree in physiological psychology and neuroscience. So I am kind of weirdly fascinated with the course of his dementia. And it's really teaching me so much about helping the person have their own agency and their own independence as much as possible.
Excellent. Thank you all. I think that deserves, let's bring the house down here, online and here. Okay, now to cap this incredible summit, I'd like to invite back up Dr. Amodeo, Carol, Amanda, and we're going to try and fit in, gosh, I think we have a good couple of minutes here. We're going to fit in questions. So Courtney and Jill, we're going to have you be our roving microphone, handheld microphone holders. So thank you all for bearing with us while we get set up, because I have to get some questions from our online audience as well. So Danielle will get the microphones for you. Right? Okay. So as we get prepared, could I maybe start with a question from our online audience? Okay, this one is addressed to Carol, but let me start, and I might have some other input. What is the best way to handle hallucinations with my spouse with Parkinson's? I try explaining that it's not real, but sometimes that makes it worse. Where do hallucinations and delusions fall in the cognitive continuum?
I'm sorry, I didn't catch most of that.
Oh, I'm sorry. Let me try again. What is the best way to handle hallucinations with my spouse who has Parkinson's? I try explaining that it's not real, but that sometimes makes it worse.
Mhm.
And where do hallucinations and delusions fall in the cognitive continuum?
Right, okay. So I think that in the case of Dottie was just saying her husband was aware of the hallucinations, and I've heard people say that. I see a dog walking around across the living room, but I know we don't have a dog. Not everybody is aware of that, right? So trying to address that with logic and reality orientation isn't going to work for somebody who has that kind of psychosis. So I think sometimes, unless it's a safety issue, I would.
Oh, my goodness.
What was that?
I think that was some audio issue, I believe. I don't believe it was anything structural. We're good. Hopefully everyone's hearing is okay. We're okay? Okay, pardon us, Carol.
So
Go ahead.
unless there's a safety issue and lost it.
I think we blew a mic.
Thank you. So I think unless there's a safety issue, I would again, I'm just trying to understand it more. If it's disturbing or causing the person anxiety or fear, you want to definitely distract them. But if they're telling you, we're just showing a lot of this, and there's no harm in it, then just go along with it. It's kind of again one of those examples of a heart. Your heart is that. So they just kind of sit back, look at that, and look at it from, look at the person doing. It makes it more interesting, and if there's some safety, I don't think there's any reason to try to bring the person back to your.
That was so important. And I apologize. I'm going to speak into this microphone, which is a Zoom microphone. I'm hoping they're hearing me because they can no longer hear us. Whereas we're using this microphone, you can hear us. So Andy, if you could give me a sign. I'm getting a little bit over here. How about, let's try. Okay. So they can hear me, but not panelists. So Danielle's going to fix that, I think. Okay. Testing. Nope, nothing yet. All right. I apologize to everyone on Zoom, and I'm sorry I'm speaking into my shirt. Hazard of this business. But we're recording everything, so no one ultimately is going to miss anything, even though you might not be able to hear it perfectly right now. But my apologies for our technical difficulty. Let's try and take a question from the audience, and there's two back there. Adrian, can you answer the question is, and I'm going to try and repeat. We're getting a question from an audience member, so hang tight, everybody. Visual disorientation? Visual distortions, perhaps? I think this is a
Can you hear?
Dr. Amodeo
Can you hear?
question. This is Zoom.
Okay, this is Zoom. Okay. Oops, should I, do you want to hand me that mic? I don't know if I need Carol. Thank you. Thanks, Carol. Okay. Yes, so excellent question about visual dysfunction that we can see in Parkinson's. And I guess along the whole spectrum of Lewy body disease. It's very complex. We think it's, not only are there changes in the eyes themselves and the speed of how the eyes move. So often people will have trouble reading because, if we think about your muscles and how they have to be coordinated, the muscles in the eyes are so little. And so they sometimes don't move as smoothly together. And so reading or things up close can be more difficult. We talked about how depth perception and the way you see the world around you can be different. So everyone's different, but some people may do better with far away. Some people may not do as well. So it's just the way that the information is taken from those pills in front of him or the TV is just taking a different path. So we think it's both cortical in the brain, there's changes, as well as the eyes themselves, the retina. All different parts of the visual pathway can be impacted, and it can be different for everyone. Yeah.
Parkinson's, right?
Yeah.
Parkinson's,
very.
no two. Okay, one more question, and I'm going to flip back to an online question. Someone's coming to you, just a minute. Can you make it a one part? I'm sorry, one part, please. Okay. Okay, so I'm gonna cut, I'm sorry to be rude and cut you off. I just want to try and get it as much as possible. CBD, cannabis, any of that stuff.
So,
What do we got?
yeah, so at this time, we don't have any, strong clinical data in our patients. There are ongoing trials and we're very much looking forward to those results. The Michael J. Fox Foundation just did a big survey among those who have tried CBD or medical marijuana in various forms. And what we've learned from that survey data is that it's generally well tolerated in our patients. And it helps with the things, I guess, that we know CBD and medical marijuana to help with: anxiety, sleep, appetite, pain. Whether it helps with the actual features that are unique to this disease, the motor features and so forth, that's to be determined. But yeah, that's what we know.
Okay, thank you. And one more before I flip back to online. Yes, go right ahead.
What practice can we make in clinical trials towards finding some sort of more intervention that stops support of
Research update, very quick.
Yeah. So there's many different aspects of research that are ongoing, so it would be hard to answer all of it, but I think the most exciting data is probably coming from that's targeting the alpha-synuclein, the protein behind the disease, which are continually ongoing, but Oh, sorry. But yes, so there's promising data looking at the protein behind the disease, and hopefully the goal is to prevent propagation. So we've a lot's in trials.
Parkinson.org is another great place to get updated information. Once again, wait 800 for PD info. Amanda, there was a really good question. They're all wonderful questions that came in I want to get to. A person is asking, how can I stop being an enabler? I help too much. I think for care partners, gosh, how can you not help too much? But maybe that's not always a good thing.
No, that's a great question. So you want to think about, what are your goals and what are your values? The goals, I think, for a lot of care partners and individuals with Parkinson's are to maintain independence, and self-independence as much as possible. And so trying to look at that goal and how are you going to do that? You're going to do that by allowing the person to try and give as much effort they can to do something on their own. And I know what that's like as a professional care partner or caregiver in a way. Doing too much I always have to remind myself that, if I do it for somebody, am I really helping them? Because then they're going to look for somebody to come and do something again for them. And help them by doing it rather than finding a way to do it by themselves or finding a way to express the need for help for some part of it and not the whole task. So I know what it's like. Try to allow the struggle by taking a few big, deep breaths and saying, let me know if I can help you with that.
I'm going to take this one. So let's take one more question from the room. And this will be our last official question of the summit, but conversations can continue with our helpline staff on Monday. We'll have a bit more conversation here in this room. So is there one more question from? Okay.
And I think it's for the time here, it's just different. The point is to take our medication that have a new schedule. And if you go to different places, you go to the home, people to hospitals, that you do it. When the patients have there's Parkinson people, how we can be able to send to make sure that we can get their medicine on time and to be certain.
And I can answer in terms of the care partner, I know, as well as for those living with it, but this is something that you as a community and the wearing care kits and are so important, and being an advocate for your loved one and working with your providers and the teams and on the hospital floors to understand that Parkinson's is a nuanced disease. They may not understand it as you do, and it's okay to be that educator. I hate putting in that position, but that is what to do. Be that advocate, be that educator. It is crucial that our patients get their medicines on time. Think about it, equate it to insulin in a diabetic. It needs to be that timely. You've seen it in our, the fluctuations can be so profound. So just be that advocate, educate, equip yourself with the Aware and Care kits. Have your movement disorder specialist phone number. I'm always happy to take phone calls and talk to the providers who maybe don't know Parkinson's and say, okay, no, an hour delay is not acceptable in this disease. And if you can't, then let them take their home medicines. Let them have it on them, because that's what we have to do. So it's just all of us working together, getting that information out.
There's such exciting work being done at the Parkinson's Foundation on this entire topic. With that, I need to bring our summit almost to a close. Nick from Acadia, please come on over. Yeah, I know you said you're going to project your voice for this room. Okay. Yep.
So first of all, I just want to say thank you for having us here at the Parkinson's Foundation Regional Care Summit. One of the things that I've learned in listening to you all is really the importance, and I know in dealing with this disease state, that being a care partner for someone with Parkinson's disease is a big responsibility. And Acadia is really proud to be a national sponsor for the Care Partner Summit. We're committed to the community that really supports those living with Parkinson's disease. Now, caregivers are often the ones who recognize some of the non-motor aspects of Parkinson's disease, including hallucinations and illusions. These symptoms can create challenges both for those experiencing them, as well as caregivers and family members who struggle with them and have concern of what that might mean for their loved one. Now, it's important that these disease states, these disease symptoms are addressed, right? And the best way to do that is to speak openly and honestly with your physician if your loved one's experiencing hallucinations and/or delusions. A special thank you to all the care partners who are advocates for their loved ones living with Parkinson's disease. That is a challenging task, and we applaud all of them. Acadia is trailblazing breakthroughs in neurosciences to really elevate life and aspires to enable brighter moments for the patients and their loved ones. So just want to say thank you for having us today, and just we value your engagement and partnership.
Thanks. Thank you so much, Nick. And with that, I will be saying so long to our online audience. So thank you so much, everyone who tuned in on Zoom. Please take a moment, take that evaluation, do the evaluation, and follow up with us. You'll be getting the recording and the slides in about a week. Thank you so much to our Zoom audience.